Okay, good evening, everyone. Thank you very much for coming to this, the 58th Maudsley Debate. My name's James McCabe. I'm the director of the Maudsley Debates, and I'm very pleased to welcome you here to King's College London for the debate. So people who are not, who've not managed to get here physically today can watch the debate via a live stream link, which we've tweeted previously, so hopefully people are looking at this now. It says off-air at the moment, so hopefully that's, that doesn't mean that we're not going out. I think we... we used to use YouTube live streaming, but for various reasons that didn't work. So now we have an extra billion people that can now watch us today, because people in China can now watch us, which they couldn't when it was on YouTube. So for any of you, at least one of that billion hopefully is watching. So hi, China, and you're very welcome. If you want to show your friends how good this debate was and want them to experience the pleasure of watching it, then you can point them to this page, which is, if you Google Maudsley Debates, you'll find it. So this is an archive of all the previous Maudsley Debates going right back to the year 2000 or 2001, I think. The first few years are audio, and then for about the last 5 or 6 years we've had them as video podcasts. So we're voting tonight by means of these response pads. So you'll see them in front of you there. You press green, which is also 1 for yes, and 2 for no or to vote against, and 3 to abstain. And we're going to have a little practice run with those in a minute. If you're not in this room and you don't have one of those things, you can still vote on your phone. And you do that by going to this website, ra.ombea.com, O-M-B-E-A. And when you get there, you will be asked for a session ID. And the session ID is 618774. That's 618774. I feel like I'm doing the kind of national lottery winning numbers or something. Some people do. So you can also follow us on Twitter. The hashtag Maudsley Debates in the plural, and also at Maudsley Debates is what you should subscribe to if you want to be notified about any future Maudsley Debates. So we do encourage people to please tweet any comments or questions to that hashtag, and sometimes we, if there aren't enough questions from the floor, we might take some questions that have been submitted by Twitter. If there's a fire, there'll be a fire bell, and you have to follow the fire exits. Please don't record or film the speakers. They're being recorded on YouTube, but please don't record on your own phones. Please do use your phones for Twitter, but turn off the sound so that they're not heard. So first of all, we have to road test these Eventbrite things. And so we're going to ask you a question, which is, how are you participating today? In other words, how did you get in here? So, and these data are actually quite useful for us in planning the debates and working out how many Eventbrite tickets we can issue. So if you came here by booking via Eventbrite, then please press 1. If you came by just turning up tonight and coming in at the door without a ticket, please press 2. And if you're live streaming, then please press 3. So this is where we get to find out if anyone is watching us through live stream. I have to press this. Okay, so wow. So we've got no one yet on the live stream, but give it time. People might not have logged in yet. I would actually ask at the back, could we actually check that the live stream is working? Because we do normally get a few, maybe 2 or 3, who are on the live stream. So most people are booked by Eventbrite, and only 9 people turned up at the door, which I'm surprised by. Actually, I think some people are perhaps not telling the truth, or possibly if you came in on the door, you're in the other room and you don't have access to this. So, to move on to the debate. So this the motion that we're going to debate here, and we're going to hear the arguments for and against in a minute, is this House believes that PTSD has been overdiagnosed in Western society. So you haven't heard any of the arguments, obviously, yet, but if you could give us your initial opinion on that, for, against, or abstain. 1 for, 2 for against, 3 for abstain, and then, of course, we'll be repeating the vote at the end of the evening when you've heard the speakers, and we'll see whether they've managed to sway your opinion one way or the other. I know, it was, well, it was, yeah. Yeah, well. So we've got, I think we'll stop it there. So we have 53 voting for, 76 against, and 52 abstentions. So there's everything to play for. And we also do a poll on Twitter, so we'll have a look at the results of that. So that's been running today, and it closed a few minutes ago. Am I doing the right thing here? Yes.
We don't care.
There it is. So on the poll, we got quite similar, actually. We've got 40% saying yes, and 60% saying no. Where are we? Have I said everything I need to say? I think I have. So all I have to do now is just introduce our chair. So our chair, Professor Sir Simon Wesley, needs no introduction, mainly because if you've ever been to one of these debates before, the chances are that he was probably chairing it, or he was on the panel, or if not, he'll have been making a lengthy contribution from the floor. So Simon is, he's the first ever Regius Professor of Psychiatry in the UK, and he's also a peer of the realm, and a past president of the, I don't know what you are, a knight, some sort of knight.
So only a subtle difference there, James.
Sorry, he's a knight, and he's also past president of the Royal College of Psychiatrists, so I'll hand over to you.
Thank you very much.
And I'll also say, sorry to interrupt you, Simon, but I initially asked Simon whether he would be interested in coming and speaking at this debate, and he said, yes, of course. I said, so which side will you speak on? And he kind of went, well, I could speak on either side, so we can't have that. You're far too balanced, so you should be chair, so he's the chair.
Good. So James, by the way, has just become a professor. Although on the space of that introduction, I don't know how or why, but he has. Well done, James. Excellent. So welcome to the Maudsley Debates. These are indeed the best free entertainment in town, second only to the Tory party leadership debates, which are almost as good. And so let's get moving. And so first of all, I have to introduce all our speakers. So directly on my left, we have Stephanie Lewis. You are one of us. You work here in Cairns, I believe. Yeah. And you are on a clinical lecturer, on a training fellowship, and you've done a huge study on life events, trauma, and PTSD in children, which is rather worrying. Suggests you know what you're talking about. So, unfortunately, we'll hear from you later. And then we've got Gerald Brennan. You are also from here, I believe. You are a consultant forensic psychologist up at Bethlehem, and you're an expert in restorative justice. That's very good. Excellent. Good. Whatever that means, I don't have a clue, but presumably that will come up. Then on my right, also from here, we have Sharon Stevelink. You are from Holland. You were born in a tiny place with only a cow and a church. That's Holland, isn't it? I thought that was a description of Holland. And you are an occupational expert, an epidemiologist, and I know because you work with me on military health. And you're also from here. Fortunately, breaking that link with here is Andrew Johns. I looked you up. You're an Australian professional rugby league player, known for marital infidelity and drug addiction. Very strange. Yes, but it's okay. Unfortunately, you are also from here. You might think that we couldn't get any speakers who weren't from here, and that would in fact be true. Why, I just don't know, but there we are. And you are forensic psychiatrist, and you do a talk called Dial M for Murder, or you do. Very good. But it's absolutely irrelevant to what we're talking about today.
We're going to the States to give the talk.
Are you
soon.
really?
Yep.
Not now. What? Okay. Well, after we finish. Right. Okay. The only thing you all have to do is keep to time. So, as once an amateur referee, you will get a yellow card with 1 minute, and if you get the red card, you finish. You aren't allowed to talk again, and you are banned for 3 more Maudsley debates. So, those are the rules. So, who's kicking off? I should know. Is it just Gerald? No, it's you, Stephanie. No. It's just Dr. Johns. Dr. Johns. Right. Okay. On my right. Good. Okay. Right. Your time has started.
Good evening, China, YouTube, and Institute. I hope you can all see me in far-off Peking. I will argue and hope to persuade you that PTSD is overdiagnosed in Western society, not that PTSD does not exist as a valid diagnosis, but it has become a socially useful concept whose function is to validate and medicalize a broad range of mental responses to trauma. I here rely strongly on the arguments of Dr. Derek Summerfield, recently retired consultant from this hospital and eloquent iconoclast. I recommend his BMJ paper, The Invention of Post-Traumatic Stress Disorder and the Social Usefulness of a Psychiatric Category. In the limited time available, I want to make 3 points. First, that PTSD as a concept has been shaped and amplified by societal factors. Second, that the wide range of mental responses to trauma are lazily and overassumed within the term PTSD. Lastly, that overuse of the diagnosis appears to validate its apparent inevitability after trauma, ignoring resilience and the capacity to readjust after trauma. My colleague, Dr. Steveling, will draw on research evidence to support the motion. A central assumption behind psychiatric diagnoses is that a disease has an objective existence in the world that exists independently of the gaze of mental health workers. In other words, a caveman exposed to a saber-toothed tiger had PTSD, as have people in all times since then. However, the story of PTSD is a telling example of the role of society and politics in the process of invention rather than discovery. The diagnosis is a legacy of the American Vietnam War and of the conscripted men who served there. A public horrified by reports of US military atrocities against defenseless peasants labeled these men baby killers and psychopaths. This reception was a primary factor in the well-publicized difficulties, such as antisocial behavior, that some military personnel had in readjusting to their peacetime roles. Those who were seen by psychiatrists were diagnosed as having anxiety state, depression, personality disorder, addiction. These diagnoses were later replaced by PTSD. The system ensured that Vietnam veterans were to be seen not as perpetrators or offenders, but as people traumatized by roles thrust on them by the US military. PTSD legitimized their victimhood, gave them moral excuse, and guaranteed them a disability pension because the diagnosis could be confirmed by a doctor. Originally framed as applying to any extreme experiences that people would not expect to encounter every day, it has come to be applied to a growing list of relatively commonplace events, such as accidents, muggings, or verbal sexual harassment. Increasingly, the workplace in Britain is portrayed as traumatogenic, even for those just doing their jobs. Paramedics attending road accidents, policemen on duty at disasters, and even employees caught up in what would once have been described as a straightforward dispute with management. All are seeking compensation for PTSD or for not being offered counselling. My second main point is that a wide range of mental responses to trauma are lazily and over-assumed within the diagnostic term PTSD. Trauma can be followed by an apparent lack of response, or by what has been called PTS or post-trauma syndrome, with features such as intrusive thoughts, upsetting memories and nightmares, anxiety or depression. In other words, there's a range of responses within the human condition, probably determined by individual resilience, These are the response by any individual to trauma, and which are surely part of the process of adapting to and coping with the effects of that trauma. Or to put it another way, I suggest that PTSD is a socially acceptable metaphor for distress, the overuse of which diagnostic term validates and medicalizes a broad range of expected mental responses. My last main point is that overuse of the diagnosis appears to validate its apparent inevitability after trauma, ignoring resilience or the capacity to readjust after trauma. PTSD is not inevitable. Take the 9/11 Twin Towers disaster. Shane Adams reported that only 13% of those actively caught up in the towers were experiencing PTSD symptoms 14 years after the disaster, with 68% also reporting depression. The broad concept of resilience is here highly relevant. This surely includes one's personal coping style, cognitive and social factors. The recent DSM-5 criteria appear to recognize the difficulties inherent in the diagnosis. DSM-5 removes the requirement for a fear-based response and has proposed greater use of the term adjustment disorder. So when does the term PTSD become appropriate? In my view, the label, the diagnosis is properly applied when it is clear that there is a dysfunction of normal and natural mental mechanisms, such that the person is unable to cognitively or emotionally process their experiences, is not as a socially acceptable metaphor for a distressed mental state. Thank you, China and the Institute.
Good. Thank you very much, Andrew. No idea what you said, but you said it to time. Okay, Stephanie, over to you. Your time starts now.
Great. So thank you very much, and thank you to Dr. Johns for raising some important points, which I'll address during the next few minutes. But I want to start by clarifying some of the terms in the motion. So firstly, a diagnosis is a description of a particular group of symptoms and other criteria, which is made by a trained clinician after careful assessment and consideration with the person affected. Secondly, we're considering the diagnosis of post-traumatic stress disorder, PTSD. So not just experiencing a trauma and some symptoms, but rather experiencing a trauma and the criteria that are set out in the PTSD diagnosis, which includes particular symptoms that are persistent, distressing, and impairing. PTSD affects only a minority of trauma-exposed people. So in this debate, we're considering whether this PTSD diagnosis is being given too much by clinicians in Western society. I don't think that this is the case. I'm a psychiatrist, and the people I see who have PTSD often tell me that they'd had real difficulty getting a diagnosis. So they'd not received appropriate treatment for some time and had worsening, distressing symptoms that stopped them getting on with their lives. And for many, their distress also led to them harming themselves and attempting suicide. I'm also a researcher, an epidemiologist, and I want to show you evidence from community studies that shows that what I see in clinic also occurs in wider society, that in fact PTSD is substantially underdiagnosed and that this is an important problem that needs to be addressed. So first, I'll show you that PTSD is under-recognised by clinicians. In order for PTSD to be recognised and diagnosed, people must first seek help from health professionals. But community studies have consistently found that of adults who meet criteria for PTSD, only about half have sought help from a health professional. And this finding comes from studies of over 42,000 people in 14 different high-income countries. Young people with PTSD have been less extensively studied, but are important to consider here, particularly because they use different services to adults. And in our study of young people, we found that of those who meet criteria for PTSD, substantially less than half had sought help from a mental health professional. So both these findings show that many, if not most people with PTSD are not even in a position to be assessed and to receive a diagnosis from a clinician. In our studies of young people, we've looked a step further, and we've investigated how many young people do receive a diagnosis of PTSD. We found that very few are diagnosed with PTSD. Only about 8% of those estimated to meet criteria for PTSD and only 18% of those with PTSD who see a health professional. So this research shows that PTSD is largely underdiagnosed, and it's largely under-recognised rather, and certainly not overdiagnosed. The second point that I want to make is that the PTSD diagnosis describes an important disorder, and therefore this under-recognition represents important underdiagnosis. In psychiatry, one of the ways that we assess whether a diagnosis has construct validity and correctly describes a disorder that's beyond usual experience and that requires intervention is to consider whether that diagnosis identifies people whose lives are substantially impaired. Well, community research has found that this has consistently been true for PTSD. And in the interest of keeping to time, I'll show you results for just one measure of this: suicide attempts, an important marker of unbearable distress. So researchers found that adults with PTSD are 6.5 times more likely to attempt suicide, and young people with PTSD are 10 times more likely to attempt suicide than those without PTSD. So just as I see in clinic, PTSD is linked with poor outcomes in the community. And importantly, this remains the case even after we adjust for co-occurring mental health conditions, showing that PTSD is uniquely linked with these poor outcomes. So PTSD is not over-medicalising all who have been exposed to trauma, but rather is identifying a minority who have a distressing and impairing disorder. The third and final point that I want to make is that PTSD can be effectively treated. And so this underdiagnosis is a problem because those who aren't diagnosed don't have access to this treatment. The recent NICE review showed that there is extensive evidence for the effectiveness of PTSD treatment. For example, adults with PTSD who have trauma-focused CBT are 3 times more likely to recover, and young people are twice as likely to recover compared to those on the waiting list. Sadly, without treatment, a substantial proportion of people with PTSD have persistent symptoms, so there is a need for treatment. By giving a diagnosis, we're identifying that need and we're enabling access to treatment. So to conclude, I've shown you that PTSD is under-recognised and that this is concerning because the diagnosis describes a disorder which is important and can be effectively treated if diagnosed. So taken together, there's strong evidence that PTSD is substantially underdiagnosed. And improving diagnosis is key to improving the care of people with PTSD. So I urge you to reject the motion. Thank you very much.
So tonight, I'm going to put to you that there's an overdiagnosis of PTSD, and consequently, the misuse of this diagnosis leads to inflation. And as the Chancellor of the Exchequer always tells us, inflation leads to devaluation. The mislabeling or incorrect diagnosis of other forms of distress as post-traumatic stress disorder undermines the existence and the severity of PTSD in general, and especially so in those populations who are potentially at risk of developing PTSD. For example, military veterans and young people, to whom my colleagues Dr. Jones and Dr. Lewis already referred to. I do acknowledge that Dr. Lewis has a point. We know it can be underdiagnosed in certain groups. However, that's not what we are debating today, as there are still many people who incorrectly get the diagnosis of post-traumatic stress disorder. Let me ask you a seemingly unrelated question. The President of the United States of America, President Trump, made a state visit to the UK last month. How many of you took the streets to protest his visit? Who feels they are suffering from PTSD as a direct result of his surprise victory of the presidential election in 2016 or his current presidency? A study conducted among 800 US university students suggested that 1 in 4 found Donald Trump's election victory so upsetting that they developed clinically significant symptoms of post-traumatic stress disorder, such as avoidance and intrusion. They even gave it a name, namely the new PTSD, the post-Trump stress disorder. Can this really be PTSD? Can there be a criterion age stressor, like a traumatic event, secondary to Trump leading the country. Keira Knightley, the famous actress who I freely admit I know very little about, reported that she has been diagnosed with PTSD. She said she struggled to come to terms with the overwhelming demands of fame at a young age, and this resulted in panic attacks and a PTSD diagnosis. Can stardom really be a criterion A stressor in isolation? These examples, and I can show you many more, illustrate why I strongly feel that inflation leads to devaluation, and it represents an insult to those who are actually affected by PTSD and are dealing with the consequences. In my view, the overdiagnosis and misuse of PTSD trivializes the condition, thereby causing skepticism and distorted views about the prevalence and severity of PTSD amongst the public, the media, policymakers, and clinicians. When you ask members of the public, like yourself, how common they think it is that military veterans have a physical or mental health difficulty as a result of their military service, 9 out of 10 will get it wrong. If I then ask about the most common mental health difficulty, most of them would see PTSD, and again, would get it wrong. Our research has shown that the prevalence of PTSD in UK military personnel is 6%, compared to around 4% in the UK general population. However, there are certain groups at risk of higher levels of PTSD, such as combat veterans, with about 1 in 7 meeting criteria for probable PTSD. Mental health problems that are common in the military include alcohol misuse and common mental disorders. However, researchers like me are also part of the problem. Research has shown that if we study mental ill health in the context of a population-based study, rather than in a study of a particular occupational group, like teachers or police officers, we find lower levels of mental ill health. This is surprising, as workers are expected to be healthier than non-workers, and also general population surveys include those with longer health-term conditions, disabilities, and the unemployed. So why might this be? This might be explained by what is called a framing effect, whereby job-related questions influence how people may respond to mental health-related questions. For example, people may use this to vent about their work frustrations and general dissatisfaction. This can influence their scores on mental health measures, resulting in a much higher prevalence than you would otherwise expect. Further, many of these surveys are being labeled as a stress and work survey or a trauma survey, again, giving rise to a framing effect. A recent example seen and widely picked up in the UK media was a study done among UK police officers, where an occupational survey suggested that about 1 in 5 police officers reported symptoms of PTSD, whereas work that we have been leading using a population-based study suggested that about 1 in 20 police officers met the criteria of post-traumatic stress disorder. Taking all of this into account, I urge you to support the motion of this House. I'm not saying that PTSD does not exist. It most certainly does. Here, as an example, the military veteran, Simon Weston, who sustained serious burns when the vessel he was on was destroyed during the Falklands War. He said that overcoming PTSD was far harder than getting over his terrible burns. His diagnosis is valid, it's understandable, and thankfully for him, his condition was treatable. I would ask you, how similar is his experience to Keira Knightley? I'm not here to degrade or deny PTSD, but I'm here to rescue it, to ensure that we go back to PTSD as a serious psychiatric illness, to how it was originally envisaged, like for those emerging out of war and for those with experiences that are well out of the ordinary. Let's value this diagnosis, not devalue it.
Good, thank you. I want to start with a historical perspective on diagnosis. This is a list of the causes of death in London in 1632. And as you'll see, there are a number of categories that we would no longer recognize as meaningful diagnoses. The rising of the lights and the king's evil are eye-catching. But my personal favorite is in the bottom right-hand corner, suddenly. Of course, we can have a chuckle about the naivety of diagnosis 400 years ago, but it is an important reminder to retain a degree of humility about the current state of our art. We would do well to consider what will seem quaint or ignorant in our diagnostic frameworks in 100 years from now. We may like to think that the current state of our knowledge carves nature at its joints, and our categories simply reflect the objective evidence that presents itself in our clinics and in our consulting rooms. However, the title of the motion we're debating this evening frames the issue in terms of Western society. And this begs the question, what light can the evidence from non-Western society shed? Much as the evidence from Dr. Lewis is that PTSD is under-recognized in Western societies, in our communities and in our prisons, it's much more markedly under-recognized in non-Western societies. And one main reason for this underdiagnosis is that non-Western societies have different metaphoric languages for communicating distress. People in the global south typically have different idioms of distress or cultural categories, often framed in terms of ethno-psychological categories of causation, different interpretations of bodily symptoms, or spiritual understandings of intrusive thoughts, and so on. It would be entirely wrong to refuse to acknowledge PTSD in a member of a non-Western society simply because they challenge the boundaries of our current diagnostic understanding. And yet this is what would happen in our own Western societies if the narrow gatekeeping function of diagnostic categorization is reified or idealized. The question posed by tonight's debate is an important and timely one. There is concern within some sections of the mental health community that the diagnosis of PTSD is being applied to trauma responses that are beyond what was originally envisaged, and that this is leading to medicalization of the human condition and creating scope for exploitation by Big Pharma. And this is not only a concern within the specific area of the armed forces, but across a number of areas of society, and as we heard, even celebrity culture, perhaps. In other words, there is a trauma revolution, and things have gone too far. But what I want to put to you this evening is that things have not gone nearly far enough, and that we are only at a beginning. We now know so much more about the nature and the effects of trauma throughout the lifespan, even in utero. The notion of a single catastrophic and life-threatening event being the dominant paradigm of experience has been exploded as being so rare that it is almost a myth. Much more common is the experience of complex, compound, and chronic trauma. And we are only at the beginning of recognizing the many ways in which multiple, unacknowledged traumas shape the mental health of our communities. How often have I, as a clinician, made an assessment of borderline personality disorder, for example, and stopped there, without adding a diagnosis of PTSD, knowing full well that the patient's presentation is as a direct result of a whole sequence of adverse childhood events, and that their responses are their attempts to cope with those events. And the same could be said for many psychotic disorders, anxiety disorders, substance use disorders, and so on. In other words, there are a great many patients for whom the current diagnostic categories are the 21st century equivalent of suddenly. Our opponents this evening will tell you that all of a sudden, everyone is getting a PTSD diagnosis, as if the diagnosis was like the M25 and the cause of congestion. But if there is congestion building up around the diagnosis of PTSD, it is because there are too few routes in our nosological systems for the life journeys that people have to travel. Those clinicians who would add a diagnosis of PTSD to a diagnosis of personality disorder, or even refuse to diagnose personality disorder in favor of PTSD, might be straining the limits of the category. But I would put it to you this evening that it is because the category of PTSD is too blunt and narrow an instrument. If it is being used beyond its original intention, it's because our original intention understood too little. We are increasingly alive to a multiplicity of trauma spectrum presentations and to the imperative to be trauma-informed. And this is true not only of mental health services, but all human service organizations, prisons, police, education, to mention just a few. As much as the diagnosis of PTSD may be straining at its diagnostic moorings, to stop using what we have to recognize trauma and its damaging effects would be as foolish as refusing to acknowledge sudden death in 1632 because there were too many. We should instead be using this to drive ever greater understanding, more research, more treatments, and ultimately more fine-grained post-traumatic stress disorder categories. But this cannot happen if we set some sort of artificial limit on the best we have. We must continue to diagnose PTSD if we are to recognize and acknowledge trauma where we find it. And I implore you to resoundingly reject this motion. Thank you.
Thank you. Thank you very much, Gerard. You had a wonderful mastery of motorway metaphors there. Very good, very good. Okay, so now we throw it open to the audience for comments, but very brief, please. We haven't got that long, so short comments or queries or whatever you wish.
I'm very persuaded by all of your arguments, but actually my clinical experience is on this side, and I want to say why I think that is. And also really respecting the effects of trauma on our patients. I'm a psychiatrist and a psychotherapist. And I think the issue is that it carries a paradigm and an approach that doesn't always seem to encompass, as you were suggesting, a person with personality disturbance, which includes relationship difficulties, as well as a lot of people saying they have PTSD when the criteria themselves are loose. So it's important to be precise about a diagnosis, but that implies a diagnosis is a precise thing. And I think the current definition of PTSD allows in woollier kind of experiences. And I think it's cutting across our patients, getting a more comprehensive assessment, analysis, way of working together to the full range of the effects of trauma when it's not an isolated, defined trauma as was originally described.
Okay, thank you very much. Who else wants to intervene? Anyone at the back? People at the back do very badly in these things. Ah, there you go. Mainly because I can't see you. Oh, shut up.
I think just building on that point, I'd kind of be curious to if it's possible to sort of square the circle by thinking that actually we do have this greater understanding of things like toxic stress and the idea that people are living in communities where they're experiencing sort of, not to diminish them, but smaller things we haven't previously recognized as traumas, and that there needs to be a space for recognizing and thinking about how we treat that should still be separable from what we've conventionally thought of as PTSD and then sort of more recently complex PTSD. I guess what I'm trying to figure out, and I'm sort of thinking about this as I speak, is how do we make room for the very real oppressions that people feel and that might be different than what we think of as normative or acceptable, while still recognizing that that's different than sort of not just a unique single experience, but the kinds of traumas that PTSD and PTSD treatments are meant to be describing.
Okay, well, you don't have long to make up your mind, and in the final vote, by the way, abstain doesn't work, so you'll have to go one way or the other. All right, we'll take one more comment or question. Yep, Andrea.
Thank you. I just wanted to bring us back to
people say who they are, by the way.
Andrea Danese, I'm a professor of child and adolescent psychiatry here. I wanted to bring us back to the question of the debate, which is whether PTSD is being overdiagnosed. And by bringing us back, I want to make 2 points. One is that for making a diagnosis of PTSD, we don't only look at exposure to PTSD, but there are a number of symptoms that need to be met. So it's not just about the trauma. The discussion about trauma is very interesting, but when we talk about PTSD, we talk about a subset of trauma-exposed individuals who also meet a set of criteria. So it's a very different thing. And the second is that just for someone to say that they have PTSD, for Keira Knightley to say that she has PTSD does not make it real. For a diagnosis of PTSD, we need to have an assessment, a diagnostic assessment, and a clinician going through that diagnostic assessment needs to make a diagnosis. So because of these 2 reasons, I think we are moving the focus of the questions a bit too far, and I think that if we keep in mind that PTSD is not trauma, and that a diagnosis is made by a clinician, there is no alternative but voting against the motion.
Okay. I mean, Gerard, perhaps I can ask you, I heard you say that you did want to expand it, because you talked about trauma-focused care and things like that, but that surely is going beyond a specific diagnosis, isn't it? You are equating it with just a trauma, finding out about trauma, which is not the same.
No, I think it's absolutely right that other aspects of the presentation need to be present. But what we know in diagnostic systems is that we have lots of subcategories. But at the moment, the subcategories within PTSD are very narrow and constraining. And it may be that what we need to do is to have an expanded umbrella category of trauma-related disorder that allows for subcategories. So, for example, in conduct disorder, you have solitary individuals and people who operate in groups, perhaps. So there may be subcategories that allow for a greater recognition that significant life traumas play a role in the symptomatic presentation.
Okay, but do we need a diagnosis of PTSD to do that? And that's a bit I'm just struggling with your argument, that's all.
Yeah, well, I suppose the point that I was trying to make is that so often when we have diagnoses now, one is enough. We tend not to have differential diagnoses, for example, or to have more than one. We end up being reductionistic in our diagnosis, and we will say, well, there's a primary diagnosis, and that trumps everything. So schizophrenia, for example, will be a primary diagnosis. We won't stop to say whether this person also suffers from a trauma-related set of symptoms that are part of their condition.
Okay. Any more questions on either side of the house here? No? You're a very unusual Maudsley audience. What's wrong with you today? Come on. Okay. Sharon, doesn't it concern you, though, that a remarkable number of children seem not to be able to get a diagnosis, let alone treatment, given that diagnosis is the first path to treatment?
I think it's concerning, and also what Dr. Lewis said. We know that there's under-recognition, but today we are debating whether there's an overdiagnosis. And whilst I acknowledge that there's far more we can do to make sure that people recognize when children present, or encourage help seeking when people are coming forward, I don't think it really supports the motion of this house today, where we're speaking about overdiagnosis in certain groups or mislabeling of the term PTSD. And also, it doesn't say in the statement that we are speaking about a clinical diagnosis of PTSD. It's overdiagnosis in general.
Okay, all right. Now, there was a flutter of a hand on my right, I think. Yeah, it's there. And just say who you are, please.
I'm Rosa, and I'm an assistant psychologist working in specialist adult community mental health at the moment. So a lot of the clients that are in our clinic have diagnoses of personality disorders or PTSD. And I'm just curious, would you see it as beneficial to potentially move away from personality disorder diagnoses and go down the route of trauma-focused diagnoses that might not necessarily be PTSD, but ones that look at the repetitive small t's, the repeated smaller traumas that one might face? And to even say, go back to Keira Knightley, it is a bit of a funny example, but if she is having repeated experiences of, say, online bullying and attacks on who she is, PTSD might just be the only label that she can reach for the traumatic response that she is experiencing.
Okay, anyway. I'm not quite sure who that question is aimed at. It's aimed at you, Andrew. You're a forensic.
Keira Knightley is an expert on mental disorders, I doubt it. I don't wish to over-rely on her function or mental health difficulties in support or refutation of the motion. I think these celebrity cases are possibly misleading. I want to make the wider point that PTSD is the sort of diagnosis that people say when they are distressed. And we've heard that it's only valid when diagnosed by a clinician, but I've sat in front of lots of patients who tell me about their diagnosis of PTSD, and they're sitting there very calmly and they don't have most of the symptoms. So that's not a valid diagnosis, but it does illustrate how the diagnosis is a metaphor for distress. And I think in psychiatry we often forget that. We don't make diagnoses in the abstract, but they are presented to us through the medium of the patient's expectation and society's tolerance of the thing called a diagnosis. Homosexuality is now not a diagnosis, it was in the 1950s.
Okay. All right. Now suddenly we've got more questions. Right, gentleman at the front, and then we go to the left. I'll start where you are now, and then come to this gentleman here. Thanks.
I just wanted to, I suppose, comment on,
Just
there was
say
a
who you
comment
are.
made, about the idea of Western society versus other cultures. And there's been a sort of growing area of research around this idea of the vulnerability paradox, that actually in cultures in which, or sort of third world countries where actually rates of trauma are higher, the rates of PTSD are much lower, and that rates of PTSD are higher in Western society countries compared to more developing countries. And so I suppose it's possible that it's being overdiagnosed, but I suppose I wonder whether it's actually a cultural influence of the fact that as sort of more developed nations, we are more prosperous, we're more individualistic, we expect more, perhaps, and so actually it's something about that sort of individualistic psychology and how we cope with sort of unexpected consequences and how they affect our ability to realize our goals and how that impacts us psychologically compared to other cultures. And maybe that's playing a role here a little bit.
Okay, thank you. Gentleman at the front. Fortunately, the unfortunate distinction of sitting next to Nigel.
Hermes Alamu, Service Manager, Mental Health Promotion, Public Mental Health. Just following the same argument, really. One of the first, probably, people who argued for the motion was Dr. Derek Summerfield, who argued and gave an example about Bosnian refugees who arrived here, and all psychologists thought that they will need the treatment, and they will lining up counselors and all that, and nobody turned up. And when they were asked really what they wanted, they actually wanted just to do work, and they just wanted a job as therapy. And the healing, probably he said, is that they should be returned where they were uprooted from. So this concept of diagnosis in general and the Eurocentric aspect of classification of mental health problems, and trying to fit these things, because there is attribution of mental health problems, there is belief systems and explanatory models as well, and people may not actually, they may experience the known symptoms of PTSD, but I think probably, I think he argued that it is a normal reaction to an abnormal circumstances which they have gone through, like trauma or bereavement.
I mean, Sophie, I remember listening to interviews with children in Sri Lanka after the tsunami, and many of my child psychiatry colleagues expressed surprise that the children seemed to be the most thing that they wanted wasn't a job, but they wanted the schools to open. And then the commentator said, well, eventually they'll realise how traumatised they are. Is that right?
Well, I think that illustrates really well the point that not all trauma-exposed people develop PTSD. And actually we know that some things that help people to recover from any symptoms that they might be experiencing are things like getting back into their usual routine, going back to school. So that may have well been very helpful for them. And certainly we would expect that not all of them would develop PTSD. And I think that relates to a lot of the points that we've heard this evening, that although trauma-exposed people may develop PTSD, they are not all likely to. But they do have an increased risk of developing other forms of psychopathology. So we've heard about other symptoms that people have mentioned that don't seem to fit the categories of PTSD. Well, we know that trauma-exposed people are at greater risk for those symptoms, but that's not what we're talking about today. We're talking about the PTSD diagnosis.
Okay. Which, of course, we keep changing. Isn't that a worry to your idea of having a nice construct validity? Every year we seem to change it.
Well, thinking about construct validity...
You mentioned it.
No matter what sort of diagnosis system we use, whether we use DSM-3, 4, 5, ICD-10, 11, sort of descriptions of PTSD.
You're making my point for me.
They are all associated with very poor outcomes, like the suicidal attempts, as I showed.
Okay. All right, I'll take a couple of last questions. Okay, I suppose, Nigel, you just caught my eye and you have the microphone next to you, so okay. I'll regret this.
Consultant Psychiatrist Priory Group. As a physician, I'm not in any way against concepts of disease and diagnosis, quite obviously. But I do wonder why post-traumatic stress disorder, as a label, would need to kind of anchor itself in something external to the individual who's experiencing that cluster of symptoms. So something objectively, so what difference in some ways does it make if somebody's pattern of anxiety symptoms, say, correlates with an objectively terrible event, like a war situation, or whether it's something that most of the rest of us would shrug off, or some of us would shrug off. I mean, the point of diagnosis is an individual patient may need some kind of help. Isn't it a bit strange that we're tying it at all to external events? Or if you look at it the other way, there's external event, and there's going to be a spectrum of responses from kind of briefly shaken up or nothing at all to severe chronic distress. Now, that variation is going to be determined by kind of biological and experiential factors. But actually, and that's what you need to be focusing on, not the label or tying it to external events. It's always what I mean is it's always happening in an individual human animal.
Okay. I'm not sure if that was the question or not, but it is the...
I heard a question. Can I...
No, you can't, because you're going to get the last thing now. Okay, so I think that's the last question. So you should have been more enthusiastic earlier. You'd have had far more time, all of you. Okay, so to sum up, so who's going first? It's Andrew.
From here or there?
Best one.
Okay, hello China, I hope you're still hearing me. Thank you. Dr. Lewis asked us to consider the notion that there is an underdiagnosis rate, but we are not considering that. The topic for debate is that it is overdiagnosed in Western society, not that it is underdiagnosed in certain groups. In fact, her paper usefully supports aspects of our case, because the evidence in that paper is that of young people exposed to trauma, the commonest after event was depression, then PTSD, conduct disorder, alcoholism, self-help, etc. A long list, to echo Nigel Tunstall's point, a broad range of mental responses to trauma. Why are we focusing particularly on this PTSD when there is such a range that require a mental health responses? Dr. Drennan invited us not to throw the baby out to the bathwater. One could not be so callous, but I'm suggesting that we have the baby in a rather smaller bath, not a swimming pool, that rather than losing the baby amidst the cloud of diagnoses around PTSD, we have more diagnostic certainty about the event. And on our side, I've argued that society creates part of the problem as a metaphor for distress, that there's a range of responses, and that overuse of the diagnosis is a profoundly unhelpful thing to the mental health professions that we all work in. Thank you.
Over to you.
So we've heard from the proposing team that there are criticisms of the diagnosis of PTSD, but they're one-off examples that they've given, and the assumptions that they've made are not supported by evidence. We accept that the diagnosis may have some limitations, as most diagnoses do. And Dr. Drennan explained that our diagnostic descriptions have evolved over time to adapt to our increasing understanding of psychopathology. And it's very likely that diagnoses will continue to develop further. But I've shown you that the current PTSD diagnosis does uniquely describe a distressing and impairing disorder in community samples that can improve with treatment. Therefore, our current diagnostic tool does have important validity and utility. I've also shown you that only a minority of people with PTSD in population representative community samples receive this diagnosis. Therefore, only a minority are able to access appropriate treatments. So there is strong evidence that PTSD is actually underdiagnosed, and that improving diagnosis is key to improving care for people with PTSD. So we urge you to vote against the motion.
Okay, good, thank you. Right, so James, you're going to take us through the voting procedures. We should remind you, I'm afraid, the vote is only open to people who are registered members of the Conservative Party.
So if you want to vote for the motion, this House believes that PTSD has become overdiagnosed in Western society. Press 1. If you want to vote against, press 2. And as Simon says, the abstain button has been disabled.
Come on, you've all done it now.
So, drum roll, please. Okay. So, the against have it, but have they won the swing as well?
Yep.
And the answer is that yes, they have.
They have,
because the 4 votes were 53 in favour and 76 against, and 52 abstentions. So I think the bulk of those abstentions have moved to the against camp. And I also noticed that we've now got 207 people in the room, where we only had about 160 before or something.
Floating voters.
So I think that's China adding to our numbers, so thank you.
Okay.
So just before we finish, we've got some refreshments upstairs, which you're welcome to come and enjoy in the hub area, as it's called. I'd like to thank all of our speakers and our chair for a fantastic debate. A very, very well-mannered debate, I thought.
True.
For our next debate, it probably will be less well-mannered, because, as you know, the 2 topics that you should never bring up at a dinner party or anything like that are Brexit and religion. We're not going to do one on Brexit, but we are going to do one on religion for the next debate. So that's going to be our autumn debate. And lastly, I'd like to thank Dr. John Tully, who's sitting at the front there, for finding the speakers and devising this particular debate. Also, as ever, to Hannah Warren, there you are, who is... sorry, what's this? Oh, somebody's left their keys. If you own a set of keys, then please come down to claim them. And also thank you to the IT team, despite the difficulties that we had there. So looking forward to seeing you all upstairs in the hub. Thanks again to the speakers.